So the two cases that Noelle and I had both centered around women with shoulder pain. So it's case one. You can read through this, but a couple of things that really stuck out to me as I was going through the case was her right shoulder pain, her age, her high blood pressure and anxiety. She does have a family history of high blood pressure, diabetes, hypothyroidism, and anxiety. She is reporting weight loss, increased stress, depressive episodes, and fairly constant pain. So these were the most likely, moderately likely, and least likely diagnoses that I came up with after going through those differentials. For this, I'm going to focus on this most likely category. So immediately I thought something with her rotator cuff, whether it was a tear, impingement, something like that, just with a loss of motion, weakness. For depression, she wasn't eating, had the weight loss, does have the history. Same thing with some of these other ones that her symptoms, her depression symptoms fit in a lot of these categories, the weight loss, and a lot of the family history of diabetes, thyroid problems. A couple things didn't fit, but as we go on, there were a couple things I wanted to look further into, whether it was a special test such as a painful arc for the rotator cuff, or asking about snapping, popping, or instability. I wanted to do some screens, whether that was a depression screen or a psychological screen for some of her anxiety. Overall, just asking about medications, changes in bowel and bladder, fatigue, and really assessing just strength and passive range of motion, active range of motion, joint play, things down those lines to rule in or out some of these diagnoses. So with some further information, we found out that she had this deep pain that would wake her up at night. This weight loss was pretty prominent. With her screens, it did come back that she has depressive-like symptoms. She was not tender anywhere, and her passive range of motion was within functional limits. So a lot of that ruled out. The MSK things moved a little bit further down on my list, such as the rotator cuff, adhesive capsulitis, and the instability. And the hypothyroidism and adrenal insufficiency, there were still further questions I would want to know the answers to. However, the cancer and the depression went a lot higher on my list, potentially indicating the need for referral. So next steps here would be just patient education and being an advocate for them, that there are resources available for her, and kind of just letting her know the results of her depression screen. But ultimately, I would refer her to her PCP because of those cancer red flags. Therefore, she could get the appropriate testing and care that's outside my scope. If both those came back negative, maybe that's when I would have the PCP step in a little bit more for a referral for an MRI or blood test or something else to rule out some of my more moderately likely, but not until seeing her PCP for those cancer-related things. So after hearing all that, what are your thoughts on what she could possibly have? Obviously, I know this is recording, so that's a rhetorical question. It did turn out that she had breast cancer. So Noelle's going to talk just briefly about how she walked through this process.
Okay, so is my sound coming through?
Yes.
Okay. So initially when she came in for right shoulder pain. And as you saw, she had she had a history of shoulder pain. So we kind of just thought it was going to be a typical shoulder eval. We noticed that she had pain constantly, so that was a little bit alarming. And then she noted in just kind of like casual conversation that she had lost weight, but she had been, skipping lunches and she was a little bit stressed out. So I think that we kind of thought, okay, well, maybe the weight loss was attributed to, her stress. So then she comes back again, and then she noted that she was having night pain. She wasn't able to sleep. Her pain was more severe. And then noted again the weight loss, like she was losing more weight, but she was happy about it. And then that essentially, we told her, this doesn't look like it could be a shoulder thing. And we did some more thorough history. And that, as a result, we referred her to the PCP because of her signs and symptoms.
So moving on to case 2.
Okie dokie. Case 2. Did you press or it's like frozen on? Okay. Perfect.
Did it go through?
Okay. So Paige's case was a 58-year-old woman who came into the clinic with bilateral walking canes, At first, she seemed a little bit confused, was not sure why she was there. She did report that she had a stroke about 4 months ago, but she didn't remember much from the stroke. She was given exercises for left shoulder pain. However, the pain is now constant at a 2 out of 10, at most getting to a 9 out of 10, and the pain often wakes her up at night. She also stated that she feels unsteady, as though her legs are going to give out at any point, but she feels safe ambulating short distances in her home. Okay, so for me, my most likely was stroke, considering that she did have a stroke previously. And I will kind of go into my reasoning on the next slide. Then in moderately likely, I had some systemic conditions, some that would explain, the weakness or the feeling of that she was unsteady in her legs and the confusion that she was having. And then in my least likely, I had more shoulder-related pathologies to explain her shoulder pain. Okay. So for stroke, what fit? Essentially, she did have a prior history of stroke. It seemed to me that she was unsteady. She had some incoordination. She was using bilateral walking canes when she came into the clinic. I attributed her feelings of like her leg to give out as muscle weakness. And then also maybe some memory deficits because she said, she was confused. She didn't know why she was at PT. For cancer, the, constant pain, she did have night pain, and breast cancer can refer pain to the shoulder. For a brain tumor, I had, changes in her mental capacity, or, her memory deficit. She seemed confused. The bilateral signs and symptoms, feeling that both of the legs were going to give out, and then some of those balance deficits. And then rotator cuff tendinopathy or a tear. This, it could be, she's 58 years old. She has some age-related degenerative changes. Sometimes associated with a rotator cuff tear. You can have pain at night, waking at night. She does have a history of left shoulder pain. There's no pain below the elbow, and she is, over 40 years old. Sorry, it's like lagging on my screen. Okie dokie. Okay, so for further examination, for a stroke or a brain tumor, any type of neurologic condition, we want to do upper quarter, lower quarter screen to test for dermatomes, myotomes, reflexes, neurotone, stuff like that. Making sure that we're assessing cognition and executive functioning and memory, and then asking some questions about bowel and bladder and sexual function. For cancer, we would ask, our screening questions are, look for red flags. So that would be, unrelenting night pain, unexplained weight loss, a loss of appetite, bumps or lumps, or any type of history. And then just maybe palpating for any abnormal lumps or masses. And then for rotator cuff tear, just assessing for atrophy, any type of weakness, especially in, external rotation, flexion, abduction, palpating the supraspinatus tendon, observing the quality of our motion, and then using our special tests, such as, painful arc, drop arm, and lag sign. Okay, so part 2, we got some more information. It was revealed that she did have diabetes, and that she rarely uses the left arm due to pain, so she needs assistance with basic ADLs. Her vitals were normal, and she was oriented ×4. Her active and passive range of motion was severely limited. She was unable to do a manual muscle test because of her pain, and her lower extremity strength was functional and normal bilaterally. She was only tender to palpation at the coracoid process, and she was able to ambulate 50 feet in the clinic without an assistive device with no loss of balance. And she stated that she did use the canes for a fear of falling. And then she was able to do single leg stance bilaterally for less than 15 seconds. So after that, adhesive capsulitis kind of popped up for me. Some of the risk factors for adhesive capsulitis and symptoms, including, she's a female, she's over 50 or 40 years old, she has diabetes, she did have a previous stroke, prolonged immobilization, maybe from her stroke, or even, she's not using the arm at all due to pain. So that kind of fear avoidance of using the arm. And then she does have functional restriction of active and passive shoulder motion. Because she was alert and oriented ×4, and she didn't have any further reports of memory deficits or cognitive decline, just maybe that confusion in the clinic was, age-related memory loss, or maybe she just she just maybe didn't really understand why she was there. Brain tumor and stroke kind of came down for me on the list. She was cognitively intact. Her fear of falling can explain her reliance on her bilateral walking canes. She had functional lower extremity strength. She did have pinpoint tenderness in the shoulder, and balance deficits are present, but they're not extremely severe. She wasn't ataxic, and her vitals are stable. For cancer, she had none of the red flags, and I ultimately ruled out rotator cuff tendinopathy because of that pinpoint tenderness to the coracoid process and the severe active range of motion and passive range of motion limitations that were present. So essentially, a treat and refer I thought was appropriate for this patient. A referral to the PCP would be needed for just some more imaging to make sure that we're ruling out any type of serious pathology. And then based on the information provided in part 2, it seemed to me that her condition may have been more MSK, considering that her vitals were stable, her sensation was intact, her strength in her lower extremity was functional. So essentially what I would do for her is assess her balance deficits, increase her confidence, considering that her fear of falling is limiting to her, and she's having to use assistive devices even when she does not need to. So increasing her balance hopefully will improve her confidence. And if she experiences any type of significant decline, then obviously an immediate referral would be needed. Okay, so think about it, and it's adhesive capsulitis. Great. So Paige, talk about your case.
So I took a similar path and thought process as Noelle. I think the big difference here is kind of seeing this case on paper versus seeing this patient in person steered me a little bit further from the neuro aspect. However, I completely see where Noelle was coming from with her thoughts on neuro. I thought it was interesting to see that her balance was a little bit limiting, but that she definitely could improve, like Noelle said, in her confidence to be able to strengthen those areas. For me, the big thing was I was unable to do a lot of tests and measures with her shoulder being as painful as it was. And so the more I was seeing how limited she was my reasoning for also sending her for a referral for imaging. And after a lot of the imaging and seeing that nothing was torn or broken, continuing to work on those balance and stuff for her walking, but then slowly progressing in a lot of the isometrics and eventually seeing that she was limited in all around limited, but you could see a little bit of the capsular pattern, which, as you know, lends to adhesive capsulitis. So there are resources, and any questions that you guys listening to this recording might have, I guess you can send to Noelle or I. All right, thank you.